Bueno, dando continuidad a nuestro simposio, vamos a iniciar la charla Manejo Hospitalario de la Falla Cardíaca a cargo de la doctora Alexandra Murawska. La doctora Murawska es médica egresada de la Universidad de Poznan en Polonia, realizó sus estudios de medicina familiar en la Universidad de Alabama y es fellowship en medicina hospitalaria en el Geisinger Medical Center en Pensilvania. La doctora Murawska se ha desempeñado como hospitalista desde el 2017. Actualmente es también presidenta del SHM, Capitulo del Norte de la Florida. Sus intereses son POCUS, falla cardíaca y educación médica. Dr. Murawska, feel welcome. Please proceed when you consider.
Thank you so much. Can you guys hear me okay? Everybody's hearing me okay?
Yes.
Okay, sounds good. Thank you so much. Thank you so much for the introduction, even though I don't speak Spanish, but I speak a little bit of Portuguese because my heart belongs a little bit to Brazil. I could understand some of the introduction. So thank you so much. Thanks for having me during this event. I wish I was there with you, but I hope I will see Colombia one day. So today I will talk to you all about heart failure from the inpatient perspective. And tomorrow I will see you one more time in the morning time, and we will talk about sepsis, which I'm passionate about. All right, so let's start. I don't have any disclosures for this presentation. What I'm going to talk about today is really, at first, we're going to a little bit talk about heart failure from the worldwide perspective. And I will really try to focus on the heart failure with reduced ejection fraction, just because of the topic of heart failure overall is so broad and big, and we really don't have enough time to talk about both. So heart failure with reduced ejection fraction would be the main topic of this presentation. And I will give you all a little bit of updates in the management at the end. So from the perspective of heart failure hospitalization, in United States, this is really number one diagnosis that is associated with the 30-day readmissions. We're dealing with over 1.2 million hospitalization annually in the United States, and we're thinking that the hospital admission for heart failure is projected to rise in around 50% over the next 25 years. Overall, worldwide, we're dealing with over 64 million people with the heart failure diagnosis, and it cost in the United States $69 billion, and that's a projected increase of cost between 2020 and 2030. 50% of those patients with heart failure will die within 5 years from the moment of diagnosis, which really put us in the moment of trying to treat these patients successfully and hoping to prevent further decompensation and sudden death. So when we're looking at the stages of heart failure, from the moment of the first onset, every time this patient is admitted to the hospital, at the end of the day or at the end of admission, when the time is for discharge, those patients are in a higher risk to be decompensated in the near future, and their quality of life decreases. So when are we talking about heart failure? We're talking, this is really just the definition, right? So the symptoms and the signs of heart failure, they're caused by structural and functional cardiac abnormalities. And we also have to have or elevated BNP level or objective evidence of cardiogenic or pulmonary or overall systemic congestion. So further edema, that's what we usually see during presentation. When we see patients with the heart failure, we're trying to stage them. We're using in the United States and also in Europe ACC or AHA stages of heart failure or NIHA classification as well. In regards of the stages, we're having stages from A to D, and that's what I'm going to focus on. So at stage A, those patients are at risk for heart failure with the elevated blood pressure, high cholesterol, history of diabetes, or underlying arrhythmia. Stage B defined pre-heart failure population. Stage C and D, we're dealing already with symptomatic heart failure patients, and obviously the stage D, which is the advanced heart failure, so that's the end of the life. In regards of NHA function classification, we're looking at those patients and see how is their activity during the regular days. So when they have a class of 1, those patients don't have really any limitation during daily life, right? So they can ambulate fine. They really don't even feel like they have any underlying heart failure issues. And then we're dealing with NHA class 2, 3, and 4. And that's when we'll start seeing some limitation in activity. And NHA class 4, those patients are unable to carry any physical activity without symptoms of heart failure or heart failure at rest. When I'm talking about heart failure stage A, those patients, again, they do not feel like they have a heart failure at baseline. We're dealing with their hypertension, we're dealing with their underlying diseases like diabetes, cardiovascular diseases, and we're trying to optimize their management of those diagnoses in order to prevent further heart failure. So optimal control of blood pressure, SGLT2 inhibitors, which I'm going to mention in the next slides, and optimal management of cardiovascular disease is something that we should really focus on patients with stage A. Stage B of heart failure, what we call pre-heart failure, those patients have already some structural dysfunction on echo. So those patients usually have ejection fraction less than 40%. And we're trying to put those patients at least on ACE or ARBs and beta blockers as well. In order of those management, in regards of ACE and ARB and beta blockers, we want to make sure that those patients are on goal dose and maximal tolerated dose of those medications, because we know already that all those medications improve mortality, and in regards of ACE and ARBs, they also improve morbidity as well. In regards of beta blockers, we're trying to we have preferred agents like carvedilol, metoprolol, succinate, and bisoprolol. So we're trying to put those patients on any of those 3 medications. There is really no class effect, and again, maximum tolerated dose of beta blocker is really important on those patients. In regards of the treatment of heart failure with reduced ejection fraction with the stage C and D, we're focusing on really truly 4 group medications at this point. ARNI or ACE or ARBs, even though I put those on like different lines, these are from the same group. We're also focusing on beta blockers, MRAs, which is mineralocorticoid receptor agonists, and the new thing in the blood, which is SGLT2 inhibitors. Diuretics, we're using them only as needed, and they're really truly only for symptoms management. So in regards of diuretics, because these are the medications that we're mostly dealing with and using when we're seeing patients in our hospital settings, we want to make sure that our patients are symptoms-free, or at least their symptoms are improved during admission. So we're focusing on those furosemide that I listed right here. So furosemide, bumetanide, which is Bumex here in the United States, are the most common used diuretics. But we also have etorsemide and ethacrynic acid, which is rarely used, but we see those patients as well. I listed some of the initial doses of medications of those diuretics right here, with the maximum daily dose that we can use and the duration of action. And again, the main goal for us, for hospital medicine physicians, are making sure that those patients are symptoms-free, or at least the symptoms are improved prior to discharge. So when they are on loop diuretics, what if diuretics are not working? What if patient is coming already on diuretics at home? First of all, we might want to make sure that those patients are taking diuretics when they are at home. When they're coming to our hospital, we'll double the dose of diuretics, sometimes triple the dose of diuretics. Sometimes we do twice daily diuretics, sometimes even 3 times. depending on the symptoms control. We see also, and we're doing this as well, we sometimes switch to another loop diuretics. For example, from furosemide, we will sometimes go towards bumetanide or torsemide, or we add thiazide as well as a booster towards the other diuretics. And obviously, if patient needs IV diuresis, that means automatically that this patient needs to be admitted to our service. So in regards of stage C of heart failure, obviously the main thing is address the volume for those patients and making sure that those patients are on 4 classes of the medications that are listed here. So beta blocker, obviously we know that it's working. We see RNEs more often. So this is a new guideline from 2022. MRAs and SGLT2 inhibitors that are obviously new guidelines as well from 2022, as well as we have some updated guidelines from 2023 as well. So when we're looking at all those 3 classes, why we chose those 4 groups, right? So our patients are always asking us why we have to put them on all the 4 medications in order for them to feel better and get better. So in regards of beta blockers, those medications are obviously very old. Remember this from our medical schools. We've been using these medications for a long time. The Copernicus trial, which was done in 2002, it was a pretty big trial. They put all the participants with the left ventricular ejection fraction less than 25%, and they randomized those patients into 2 groups, a carvedilol group and the placebo. And they were looking at all-cause mortality, deaths, and cardiovascular hospitalizations. And we saw that carvedilol was associated with reduction of all-cause mortality, cardiovascular death, and hospitalization for heart failure. So we knew from all this time that beta blocker works, decrease mortality, and from our perspective, hospital medicine perspective, reduced hospitalization, which was a big thing. So in regards of ACE inhibitors, so we had another trial that was even older from 1991, SOLVE trial. Similar presentation. They put 2 groups, placebo versus enalapril, with the patient population over 1,000 people. And same thing, they were looking at death, hospitalization, cardiovascular deaths, and all-cause mortality. And the conclusion was same as with beta blockers. Enalapril was associated with reduction in all-cause mortality, cardiovascular death, and hospitalization for heart failure. So I remember even when I was finishing my residency, we always had to put those patients on beta blockers and ACE inhibitors. But then we start seeing more data and more research about another 2 groups. So after enalapril, after ACE inhibitors, we found that Entresto is actually doing pretty good job. So this was a big study in 2014 paradigm heart failure trial, and they put over 4,000 people in Entresto group versus enalapril group. Similar results we found. They were looking for cardiovascular death and hospitalization, and overall hospitalization for heart failure. And what was the conclusion? That Entresto was associated with a reduction in cardiovascular death and or hospitalization for heart failure. From hospital medicine perspective, this was a big thing. So we've been started seeing patients on Entresto rather than ACE or ARBs. Next trial was a RELS trial, and they were comparing placebo with spironolactone. That was a 1999 trial, pretty old, but what was really amazing about this trial, that this trial was discontinued early because they already know early enough that spironolactone works for patients with the heart failure. So all-cause mortality was reduced in patients who were on spironolactone, and heart failure hospitalization as well. Obviously, the biggest side effect of spironolactone was gynecomastia. But this was the biggest side effect that they found. So overall conclusion was that spironolactone was associated with the reduction in mortality and hospitalization for heart failure. From that moment on, we start adding MRAs to our patients who were having heart failure with reduced ejection fraction, and continue monitoring them, and we were seeing a big improvement in overall function. But the biggest thing right now is really the SGLT2 inhibitors. We know how this medication works. It blocks resorption of glucose in proximal tubule. Action goes well beyond glucosuria and natriuresis. So we're thinking that because patients are peeing so much, it almost works as a diuretic. So FDA approved this medication for diabetes since 2012. But for heart failure, we've been seeing that FDA approved this medication since 2020, and we have additional guidelines in 2022 from AHA and ACC, as well as European guidelines that promote this medication to be put on for patients with heart failure. So they had another trial regarding SGLT2 inhibitors, and that was DAPA trial in 2019. And after this trial, that's when they updated all the guidelines. So the participants were having ejection fraction less than 40%, and they randomized these patients to placebo group and dapagliflozin. They were looking for similar things as the previous trials, so cardiovascular death, hospitalization, need for diuretic therapy, which was addition to what we were saying before. And what we see in the conclusion was that the dapagliflozin was associated with a reduction in cardiovascular deaths, hospitalization, and the need for IV diuretic therapy, which, again, from our perspective, hospital medicine, it's a huge thing. So what do we need to remember really about SGLT2 inhibitors? We have a couple medications right now on the market. The most common one is dapagliflozin and empagliflozin. We usually start with the 10 milligram dose of those medications. These medications are very good for patients with NYHA class 2, 3, and 4. They are safe for patients with diabetes type 2, but we should not give this medication for patients with diabetes type 1. Do not initiate this medication if the GFR is less than 25 for dapagliflozin or less than 20 for empagliflozin. And obviously, when patients start being on dialysis, we should stop using this medication, and to withhold this medication for 3 days before major surgery or procedure. So do we really need all this medication? And the answer is yes. We know that GDMT works. They were comparing those 4 medications with the previous ACE, ARB plus beta blocker, and we see 62% reduction in cardiovascular death, hospitalization risk, 50% reduction in cardiovascular death overall, and 47% reduction in all-cause mortality risk. So adding additional 2 medications for those patients creates such a big improvement in overall function, and really were prolonging their life. So what are the really common precipitants of heart failure when we see those patients in the hospital? Why do we even see them? Most of the time, what we see, especially in some of the population here in the United States, they're just forgetting these medications. There's too many medications that those patients need to take. Underlying arrhythmia, anemia is another big precipitant factor for those patients to be admitted. Ischemic event, any infection, put those patients on the line to be admitted for heart failure exacerbation. Lifestyle, big thing, alcohol use, salt intake, illicit substances, those lifestyle modifications should be also implemented. And upregulation of cardiac output. We see patients who are pregnant, having hyperthyroidism, who are not on a guideline-directed medical therapy. They are having higher risk to be admitted in the future. Renal failure, big thing, and pulmonary embolism or any other lung disease can also throw those patients into exacerbation of heart failure. So what are really the criteria for admission from ED? When those patients are being seen by our ED physicians, at what point we're going to be called to admit these patients to our service, to hospital medicine, where we see the critical illness at presentation, obviously hypoxia, hypotension, cardiogenic shock. Those patients needs to be admitted. New diagnosis of heart failure, obviously it's a big one. Marked congestion with incomplete response to initial therapy. Usually after initial dose of IV diuretics in ED, if those patients are not getting any better, those patients needs to be admitted. Evidence of ischemia, if we see any uptrend of troponins, uncontrolled arrhythmia or infection, we also admit those patients to watch them a little bit more closely for the next couple of days. And the big thing, significant lab abnormalities, right? Renal dysfunction, hyponatremia, hyperkalemia. It's a big thing, especially if someone is on MRAs or ACE or ARS or ARNI as well. And poorly managed comorbidities, such as COPD or underlying diabetes, is also a precipitant factor for those patients to be admitted. But at what point we're consulting cardiology? We know we can do so much as a hospital medicine physicians, but obviously we're working closely with our cardiology team, our critical care team. So when are we calling our colleagues to help us? When patient needs to be in ICU, when they need to be put on pressors, we're calling our ICU team. When we see this typical cold and wet hemodynamic profile for those patients, we're calling our cardiology team to help us with that. High risk per adherence risk stratification. So adherence risk is looking usually for the BUN, creatinine, and blood pressure. And if we see those patients are not doing well, we're calling our cardiology team to help us with that. Ischemic symptoms, any changes in EKG, any elevations of troponins, we're asking our cardiology team to also help us. With severe valvular disease, if something is especially new on echo, underlying AFib with RVR, ventricular tachycardia, if we cannot control this well during the first couple hours, we also call our colleagues. And persistent congestion. If someone is not responding well to initial diuretic therapy, if they are on drips and not getting any better, if we see that they have worsening kidney function or liver function, we're also asking our friends from the other departments to help us. So what's going on in Europe, knowing that I'm from Europe? In 2021, European Society of Cardiology guidelines recommend use of 4 different classes of drugs, which we already know. And in 2023, they updated their guidelines, suggesting that intensive strategy of initiation and rapid titration of evidence-based treatment before discharge is actually helpful. Before, we were trying to be really cautious with those medications because they were new, especially SGLT2 inhibitors. We've been seeing this a lot, that we're just worried to start new medication because we do not see those patients as an outpatient. If those patients are not seen quickly enough by cardiology or primary care, we're losing the track of those patients. So we want to make sure that those patients are followed up closely. But because of the new guidelines, now we're trying to see if actually rapid up titration and starting this medication, even during our first admission, or doesn't matter which admission, but during the admission, it's actually helpful for those patients. So they did a recent study that's actually from this year, from American Journal of Cardiology. They were comparing 2 groups who were between whoever was starting on GDMT during the first month versus who was the group who was starting with the rapid titration of this medication from the moment of admission. They were comparing heart failure, hospitalization, cardiovascular death, and composite of both between these 2 groups at 6 months follow-up. And what they found out is that heart failure hospitalization risk was lower in group 1. There was no significant changes in cardiovascular death between the groups or composite of both. So from our perspective, it looks like if we start those patients soon enough and quickly enough on those 4 medications, we will not see them as often during the next upcoming months. So what is really effective in hospital care? Obviously, diagnostic evaluation, which starts in our ED department. Triage and risk stratification, it's a big one. Early implementation of guideline-directed therapy, and we're trying to implement this as soon as we can. Appropriate diuresis, making sure that those patients are as symptoms-free or at least the symptoms are controlled. And appropriate discharge planning. We want to make sure those patients are follow up closely on discharge, and someone is seeing them hopefully within the first week. And obviously, we're talking with our PT team, case managers team. Some patients will need to go to rehabilitation, including cardiac rehab. What are the gaps that we're still having here in the United States, and I'm assuming around the world, is lack of awareness and the lack of time to really explain and educate our patients that those 4 medications are really important for patients with the heart failure. Limited experience in heart failure management. We want to make sure that our colleagues in hospital medicine and primary care physicians are not only experienced, but they feel comfortable to manage those patients. Insurance barriers, systems issues, big thing in United States that we're trying to deal with. And again, poor patient education, especially in patients in some areas of United States. So initiation of GDMT is safe and is needed, and we know that. They reduce the risk of subsequent hospitalization. If patient is on GDMT, it needs to be continued during hospitalization unless truly there is some contraindication. If the beta blocker is stopped, we should always restart this medication, even if it's on the lower dose prior to discharge. And if patient is on diuretics, we should put them back on the same or higher dose on discharge, with the goal negative fluid balance being 500 mL at least. And patient, again, they need close follow-up within the first 2 weeks. This is very crucial for the patients to be evaluated quickly enough after discharge, and to make sure that they are continue taking this medication, that they understand why they need to take this medication to prevent further hospitalization. And that's all what I have. Knowing that I'm going to see you all tomorrow. If you guys have please any questions, let me know. And I want to take a quick moment and invite all of you guys to our Mayo Clinic Hospital Internal Medicine Conference that is next year in Italy. So if you have time next September, please join us. You will see some of us there. And thank you so much.
¿Hay alguna pregunta del auditorio? Thank you for your conference, Dr. Murawska. There are no questions from the assistants.
Thank you. Have a good day.
Bueno, damos paso a la conferencia Fe y Preservada. Es hora de hablar. Revisemos las guías de diagnóstico y tratamiento a cargo del doctor Eric Castaño. El doctor Eric es internista de la Pontificia Universidad Javeriana, cardiólogo de la Universidad del Bosque, especialista en insuficiencia cardíaca de la Universidad Católica de San Antonio en Murcia, España. Está certificado en estudios avanzados en insuficiencia cardíaca de la Universidad Pontificia Bolivariana y es cardiólogo del Instituto del Corazón de Bucaramanga en la Clínica Foscal. Bienvenido, doctor Eric.
Bueno, yo no voy a dar la charla en inglés, la voy a dar en una combinación entre rolo y pseudo santanderiano. Muchas gracias al Capítulo Santander de la ACMI por permitirme venir a divertirme aquí un rato y mostrar de pronto qué hacemos nosotros. Y mi mayor conflicto de intereses el día de hoy es que ojalá aprendamos entre todos. Cuando me pidieron el favor de dar esta charla, yo dije, bueno, ¿por dónde empezamos? ¿Sí? Y pues pensé que la mejor forma de hacerlo era pues la enfermedad o el síndrome de falla cardíaca a hoy es una de las enfermedades más prevalentes en el mundo. Tenemos más de 60 millones de personas, conviviendo con insuficiencia cardíaca. Es una de las principales causas de morbimortalidad no solo en Colombia, sino en el mundo. Y pues eso representa obviamente una alta carga para el sistema de salud, tanto en costos, medicamentos, rehospitalizaciones. Se está devolviendo. Listo. Cuando uno busca en la literatura falla cardíaca preservada, a uno le pareciera que es una enfermedad nueva. Cuando uno busca en PubMed falla cardíaca preservada, mire que no hay casi artículos, no hay casi póster, no hay casos clínicos, cuando realmente es una enfermedad con la que estamos conviviendo hace muchos años, ¿sí? Y es porque el término falla cardíaca preservada se volvió un diagnóstico más actual, y antes la veíamos probablemente como ustedes de pronto en su ejercicio la veían, como la famosa disfunción diastólica. Y siempre pensamos que la falla cardíaca a hoy preservada tenía que ver con un trastorno en la relajación, en un trastorno de pronto en la motilidad del ventrículo, y a hoy sabemos que no. Y miren que después del 2018 la cantidad de papers, la cantidad de estudios en falla cardíaca preservada, pues con ese diagnóstico ha ido aumentando. Y cuando uno se va a buscar la epidemiología de la falla cardíaca, hoy sabemos que el 50% de nuestros pacientes, traducción, la mitad de nuestros pacientes tienen FEBIs preservadas, ¿sí? Y dentro de esos pacientes, desafortunadamente las mujeres son las que más falla cardíaca preservada tienen, ¿sí? Y en los estudios nosotros vemos que a las mujeres desafortunadamente en comparación a los hombres con falla preservada les va peor. Es por eso que debemos empezar a hacer un análisis y digamos un diagnóstico más temprano de esta entidad. Y cuando uno va y busca una gran mayoría de estudios de falla cardíaca, miren que la gran mayoría de pacientes en esos estudios, miren en qué fracción de eyección están. Bueno, la gran mayoría, discúlpenme que esto no está alumbrando casi, pero miren, la gran mayoría por encima de 50, y no me quiero adelantar a algo que voy a hablar ahorita, pero todos. Y desafortunadamente, la que más sabemos manejar, la que en teoría tiene muchos medicamentos, la que de pronto todos somos muy expertos, el famoso término que empezó a hacer de moda de los 4 fantásticos, de todo esto, sirven para la menor población con diagnóstico de falla cardíaca. Entonces vayámonos a la definición. ¿Cuándo hablamos de falla cardíaca con fracción de eyección preservada? Afortunadamente en el 2021 los comités de diagnóstico de falla cardíaca llegaron a un consenso en el cual ya sabemos que la falla cardíaca no es una enfermedad sino un síndrome en el cual se acompaña de signos y síntomas sospechosos de falla cardíaca, una elevación de péptidos y la evidencia objetiva de algún grado de congestión. Esto permite que si usted tiene un paciente con estas características, lo pueda clasificar dependiendo su función ventricular, y al día de hoy hablamos de falla cardíaca con fracción de eyección preservada, aquellos pacientes en los cuales, ¿esto ustedes sí lo están viendo o soy yo el que no lo ve? Por este cosito. Bueno. Cuando yo hablo de falla cardíaca con fracción de eyección preservada, tengo que referirme a aquellos pacientes en los cuales les he encontrado una función ventricular izquierda mayor al 50%. Con esto, pues probablemente ustedes estén haciendo la misma pregunta que yo, hasta ahorita. Bueno, ¿y qué causa eso? ¿Qué hace que yo tenga un paciente con fracciones de eyección por encima de 50? Y alce la mano los que piensan, hasta hoy, yo sé que no porque ya muchos de ustedes han leído sobre el tema. A hoy, muchas personas piensan que tener fracciones de eyección por encima de 50 es, pues el señor está bien, ese paciente está bien, tiene 50, doctor, Yo no sé por qué se queja el señor si tiene 50. Mandémoslo al psiquiatra porque de pronto esa disnea, eso que tiene, de pronto eso es por otra cosa. Y no, doctores, sí es el corazón. Y hoy sabemos que la fracción de eyección preservada, la falla cardíaca con esa entidad, es una enfermedad multisistémica, ¿sí? La falla cardíaca con fracción de eyección preservada es la sumatoria de muchas patologías o de muchas comorbilidades que tiene el paciente, principalmente la obesidad, la hipertensión, y toda esa sumatoria hace que haya una inflamación a nivel endotelial. Esa inflamación a nivel endotelial, pues tenemos endotelio en todas partes, eso hace que pueda tener alteraciones renales, alteraciones cardíacas, obviamente, a nivel pulmonar, cerebral. Es una enfermedad que no la debo tratar como solo una enfermedad del corazón. Y es un síndrome, y al ser un síndrome yo tengo una gran gama de colores, no tengo un blanco y un negro, sino literalmente voy a tener una escala muy alta, donde yo voy a tener pacientes que tienen una comorbilidad que me pueda explicar. Es un síndrome donde lo voy a ver más de pronto en obesos, donde tengo inflamación, la diabetes juega un papel muy importante, ni se diga la fibrilación auricular, y con eso entonces voy a empezar a tener alteraciones en la función ventricular, alteraciones a nivel de la sangre con mayor viscosidad, aumento de las presiones, alteraciones en el riñón, y esto sumado me va a hacer entonces que yo tenga disfunción ventricular, derecha, izquierda, o sea, mire que realmente si yo quisiera saber cuál es la causa de la falla cardíaca preservada, pues no voy a tener algo fijo que me diga la causa fue esta. Y miren que en esa gama de colores yo puedo tener pacientes de todas las características posibles, ¿sí? Y cuando uno mira todas las etiologías y causas de fibrilación, de falla cardíaca, yo tengo casi siempre los menores de 40, van a ser de pronto los isquémicos, los chagásicos, ¿sí? Pero cuando yo me voy a los mayores de 50 en la FEBI, la diabetes, la dislipidemia, la anemia, la misma enfermedad isquémica, la fibrilación auricular, la hipertensión, las alteraciones renales, y eso hace que todos los pacientes con falla cardíaca preservada tengan un fenotipo diferente, ¿sí? Eso hace que hoy en día la falla cardíaca con fracción de eyección preservada sea una entidad que usted debe individualizar, donde debe ser usted una persona que ayude a que su paciente usted lo pueda ver como un solo sujeto, que no todos son iguales, y eso le va a permitir tratar realmente todas las cosas adicionales a las que tiene su paciente. Y siempre pensamos que los corazones de los pacientes con falla cardíaca también eran iguales. Los de reducida, discúlpenme, son muy fáciles. Corazones, como decimos acá en el argot popular, grandes, corazones dilatados, corazones delgados, pero realmente el fenotipo de los pacientes con falla cardíaca preservada, miren todo el espectro que puede tener. Yo puedo tener un corazón pequeño con fracción de eyección reducida de pronto o preservada. También puedo tener un corazón más grande, con volúmenes más grandes y tener fracciones de eyección preservada. Puedo tener alteraciones valvulares. Entonces me puedo mover en todo este espectro, y al tener todo este espectro, pues literalmente los cambios hemodinámicos, los cambios fisiopatológicos, los cambios a nivel pulmonar van a ser totalmente diferentes. Con todo eso que usted está hablando, doctor Eric, pues espero que ustedes también se hagan la pregunta que yo me hice cuando empecé a leer para esta charla hoy, ¿sí? Bueno, y si usted me está hablando de que eso tiene una gama de colores muy alta, que esos corazones son todos diferentes, que pueden ser obesos, eso, pues, ¿usted cómo va a hacer para diagnosticar esta situación si se está enfrentando a una gran gama de patologías? Probablemente lo que más se va a quejar un paciente con esta condición es de disnea, doctores, ¿sí? La disnea es una de las principales causas que hace consultar a estos pacientes, y entonces usted trate de saber cuál es la causa de su disnea. Y hoy yo les traigo unos tips. La disnea puede ser probablemente cardíaca, puede ser pulmonar o puede ser por cualquier otra causa. Entonces, cuando usted tenga un paciente con disnea, mire de pronto si es que yo lo puedo meter en este grupo de pacientes. Y si yo pienso que la causa es pulmonar, pues empiece a buscar patologías pulmonares. ¿Será que tiene un EPOC? ¿Será que tiene un EPID? ¿Será que tiene una neumonía? Oiga, no, yo creo que ese paciente va por el lado cardíaco, la causa de la disnea. ¿Será que ese paciente tiene una cardiopatía? ¿Será que es isquémico? ¿Será que tiene algo valvular? No, yo no creo que tenga que ver entre el pulmón y el corazón. Yo creo que la disnea puede ser de pronto la anemia. Entonces, hacer un buen interrogatorio de probablemente que se enfrente usted con disnea. Y cuando usted tiene un paciente con disnea, podría aplicar esto. Haga un buen interrogatorio, signos y síntomas, y si usted piensa que su paciente es cardíaco, el primer tip de hoy: utilice la escala probablemente más sencilla, la que tenemos más a la mano y que nos queda muy fácil, el famoso H2-PEF. Es una escala fácil, es una escala que tiene estas variables y es: mire si su paciente está hipertenso o está obeso por encima de 30, esa es la H. Mire si su paciente tiene alguna alteración eléctrica tipo fibrilación auricular. Mire si su paciente, acuérdense que en el algoritmo diagnóstico de falla cardíaca tenía yo signos y síntomas, probablemente alteraciones en los péptidos, y trate de clasificarla con un ecocardiograma. Entonces, probablemente acá, mire si ya tiene algunos signos de hipertensión pulmonar. La falla cardíaca preservada es más frecuente en personas mayores. Y pues algo que va al segundo mensaje de hoy: los ecocardiogramas no es solo la FEBI, doctores, ¿sí? Porque ¿para qué pido un ecocardiograma? Quiero saber la FEBI, doctor, le salió en 50, bueno, está normal. Y no es así. El ecocardiograma les va a dar mucha información adicional. No necesitamos ser ecocardiografistas expertos en el ventrículo izquierdo, strain longitudinal, resonancia, para saber que podemos ir a mirar esta variable, ¿sí? Yo sé que muchos de los que están aquí sentados, sobre todo por ese lado, sin de eso, saben que la onda E y la onda E' nos van a mirar disfunción diastólica, ¿cierto, doctor Martín? Entonces, las ondas E y la onda E me van a mirar relajación de la aurícula y me van a mirar la función valvular mitral. Cuando yo las comparo, si yo tengo unas relaciones por encima de 9, es muy probable que tenga disfunción diastólica. Traducción: muy probable disfunción ventricular, falla cardíaca preservada. Esa es la fácil, porque entonces, como todos, a mí me dijeron, cuando un cardiólogo no hable de una escala en una charla es porque probablemente no es una charla de cardiología, ¿sí? Entonces, todas las enfermedades cardíacas tienen una escala. Entonces, súmela. Si esa escala le da menor de 2, su paciente no tiene falla cardíaca preservada fijo. Si le da mayor de 5, su paciente tiene fijo una falla cardíaca con función de eyección preservada y usted podía parar. Pero como no todos dan ni menos de 2 ni más de 5, pues nos pasa lo que nos pasa en muchas entidades: las famosas zonas intermedias. Y en las zonas intermedias nos empezamos a embolatar, como decimos en el argot popular. Entonces, si usted tiene una escala en una escala intermedia, pues de pronto váyase a una escala que le pueda ayudar un poco más. Y esa escala que le puede ayudar es la famosa HAF-PEF. ¿Por qué? Porque es que si ustedes se dan cuenta, en el diagnóstico de falla cardíaca existían los péptidos. Y miren que en esta escala, que es muy sencilla y donde uno debería empezar, no meten los péptidos, mientras que este sí los mete, y aparte le dice a usted: evalúe otras cosas del ecocardiograma que le van a ayudar al diagnóstico de la falla preservada, ¿sí? Entonces, si yo hago la escala, pues voy a ir a mirar. Esto todo se lo informa el ecocardiograma. Yo no tengo que ser un experto en la lectura de ecocardiogramas. Voy y miro el grosor relativo de la pared, voy y miro el volumen indexado de la aurícula, voy y miro la famosa relación de la onda E, la onda prima, miro, nosotros lo informamos en los ecocardiogramas, la velocidad de la tricúspide, y eso me va a dar unos puntos también. Y ahí viene el otro complique otra vez. Si yo aplico esta escala y en esa escala me da menos de 1, mi paciente no tiene falla cardíaca con fracción de eyección preservada. Pero si mi paciente en esa escala me puntúa más de 5, fijo tiene fracción de eyección preservada asociada a síntomas de falla cardíaca. Problemita. Si me sale intermedia, ¿qué hago, doctor? ¿Sí? Entonces, ahí probablemente usted dice, no, yo se la mando al cardiólogo, que la vean en una clínica de falla cardíaca, que esos manes son los que saben de falla. No, ustedes pueden hacer muchas cosas aparte. Y es, si usted tiene que hacer la escala de el H2PEF, ya hizo todo su interrogatorio, ya tiene un ecocardiograma, ya tiene los péptidos, pues le va a tocar empezar a hacer pruebas adicionales como probablemente pruebas de ejercicio, un ecocardiograma de esfuerzo, un cateterismo derecho, algo que le ayude más. Raro que usted llegue hasta acá probablemente con las escalas, si las hizo bien. Entonces ahí un mensaje que yo quiero que ustedes se lleven hoy. Estas es las variables que le digo del ecocardiograma del H2PEF. Y este es el mensaje que yo quiero que ustedes hagan. Perdón, les muestro algo antes. Esto se los había adelantado. Esto es como nosotros valoramos la onda E y la onda A. La onda E y la onda E'. Este es un ventrículo de un paciente. No quedó en movimiento, no sé por qué. Supongo que me voy a devolver. Y la paso y ahí debe. Eso. Si yo tengo un paciente con un ventrículo que a mí me parece relativamente normal, yo me puedo ir a parar en la tricúspide, me puedo ir a parar en la mitral y voy a obtener estas imágenes. Esta se salió. Eso es una falla cardíaca con fracción de eyección preservada. No, mentiras. Aquí vamos. Ay. Ahí. Esta es la onda E, esta es la onda E'. La relación entre las dos, en teoría miren que siempre yo voy a tener una onda E mucho más alta que la onda E'. Y pues si yo tengo esas relaciones alteradas, las voy a ver como probablemente diagnóstico de disfunción diastólica. Ese es el dato clave que yo quiero que ustedes se lleven con las escalas. Lo estudié la disnea. Lo primero que yo debería hacer es haga la H2PEF, la que les dije del índice de masa corporal, la de la hipertensión. Si me da baja probabilidad, descarté la enfermedad. Si me da alta probabilidad, la confirmé y ahí me puedo quedar. Pero si yo hice esta escala y me dio intermedia, vaya a mirar las variables del ecocardiograma y aplique todas las variables del H2P. Y con eso usted podría llegar al diagnóstico. Si no llegó ahí, pues le toca hacer pruebas funcionales. Y las pruebas funcionales solo quieren mirar aumento de las presiones dentro del ventrículo, aumento de las presiones a nivel capilar. Y yo necesitaría un ecocardiograma de esfuerzo, pero hay un consejo, doctores. Cuando ustedes piden un ecocardiograma de estrés, un ecocardiograma de esfuerzo, ¿qué les informan normalmente? Negativo para isquemia, doctor. Cuando usted pida un ecocardiograma pensando en falla cardíaca preservada, dígale a su ecocardiografista de confianza, doctor, yo no le estoy pidiendo el ecocardiograma estrés para saber si tiene isquemia o no. ¿Será que usted me puede ayudar bastante en decirme si tiene disfunción diastólica? ¿Será que usted puede mirar si le aumentó el gradiente? ¿Será que le aumentó eso? Y con eso usted podría saber dos posibilidades. Si usted ve que la presión pulmonar está por encima de 16, si usted cumple diagnósticos de falla cardíaca preservada, si usted hizo cateterismo derecho y apenas entró en reposo, su cuña es por encima de 15, es muy probable que usted ya tenga una falla cardíaca preservada. Si no tiene esa condición, haga el ejercicio. Y si usted se da cuenta que con el ejercicio Es muy difícil de hacer esta prueba. Es tener un swan ganz acuñado, como decimos en el argot popular, y decirle al paciente, empecemos a hacer ejercicio, ¿sí? Perdón el ego, donde yo hice falla cardíaca, teníamos a los pacientes en una posición como las famosas mesas basculantes, con el catéter aquí puesto y pedaleando, ¿sí? El paciente empezaba a pedalear, íbamos midiendo las presiones y si la presión se aumentaba a más de 25, ese paciente tiene falla cardíaca preservada. Entonces yo ya la diagnostiqué, ya me puse en toda la tarea de hacer las escalas que la verdad con el solo H2PEF yo podría tener, ¿sí? Pero realmente llegar hasta estas pruebas avanzadas, pues son muy raros los pacientes que usted ya no alcanzó a diagnosticar. Pero suponga que sea la escala que sea, el ejercicio diagnóstico que usted hizo, usted dice, sí, mi paciente cumple todos los criterios para una fracción de eyección preservada. Y doctor, ¿ahora cómo la va a tratar? ¿Usted qué va a hacer con ese paciente? Cuando uno miraba las guías, pues yo me ponía a llorar hace unos años. ¿Qué decían las guías de falla cardíaca preservada? Doctor, trate todo lo que le pueda dar falla cardíaca. Ponga al paciente en menos peso, trátele la diabetes, trátele la fibrilación, dígale que haga ejercicio, mire a ver si tiene un SAOS, pero realmente lo único que servía en falla cardíaca preservada hace unos años, de pronto los diuréticos. Dele alguito de diurético y doctor, trate de manejarle las comorbilidades, ¿sí? Entonces a este tiempo muchos cardiólogos le decían a los pacientes algo de pronto un poquito feo. La falla cardíaca reducida te puede matar. La falla cardíaca preservada te acompaña mientras te mueres, porque realmente no había muchas cosas que pudiéramos ofrecerle a esos pacientes aparte de las comorbilidades. Para fortuna de esos pacientes, empezamos a mirar que de pronto habían unas vías en las que yo podía actuar. Y aquí empezó el error en los cuales muchos de los estudios previos no servían. Y es porque siempre pensamos que la preservada era igual que la reducida. Y si ustedes se dan cuenta, tiene una fisiopatología, una etiología, unas cosas que no son iguales a la reducida, son completamente diferentes. Y por eso uno trataba de mirar, ¿será que los inhibidores de la neprilicina sirven? Porque en la reducida sirven mucho. ¿Será que los ILST2 sirven? Porque sirven un montón en la reducida. ¿Será que los inhibidores de los mineralocorticoides sirven? Y todos ellos iban y actuaban y pensábamos muchos, pues es que eso es lo mismo. Entonces, pues si yo inhibo la neprilicina, pues voy a tener menos inflamación. Si yo disminuyo la absorción de sodio, la absorción de potasio, si yo le doy más fuerza de bombeo al corazón, pues eso debe servir igual. Y desafortunadamente, todos los estudios que se hicieron en preservada nos ponían a llorar. Empezamos con los inhibidores de IECA y ARA2, el famoso estudio CHAR con losartán, con candesartán, no sirvió. El TOPCA con espironolactona no sirvió mucho. La doctora ya nos habló un poquito del Paragon, en preservada no sirvió mucho. Y llegaron los ILST2. Y para fortuna de muchos, los ILST2 mostraron lo que tanto esperábamos hace mucho rato. Podemos ya contar con moléculas que nos ayuden al tratamiento. Entonces, ¿de dónde nació eso? Ya sabíamos que la empaglifosina, el ILST2, había servido en reducida, había servido en reducción de hospitalizaciones por falla cardíaca. Pues hagamos el mismo estudio, pero en aquellos pacientes que cumplían criterios de preservada. Un estudio relativamente fácil de hacer. La molécula contra el placebo y miremos qué pasa. Y para fortuna de los pacientes con preservada, los pacientes al seguimiento empezaron a mejorar. Y miren una cosa que a mí me gusta de este estudio. Cogieron pacientes que tenían cerquita al 50, de pronto 49, 48, porque pues acuérdense, 49 será que yo la trato como preservada o como reducida, entonces el intermedio siempre, ¿cierto? Cogieron a los mayores entre 50 y 60 y a los de 60. Y los resultados pues me empezaron a ayudar que estos pacientes en el seguimiento disminuían la cantidad de hospitalizaciones, disminuían la cantidad de ingresos por falla cardíaca descompensada, empezaban a mejorar los péptidos, empezaban a bajar de peso, empezaban a bajar la hipertensión, empezaban a disminuir la cantidad de fibrilación auricular. Y ustedes de pronto, si se han leído el estudio, siempre me corchan con una pregunta y todos se van por ese lado. Pero eso no disminuyó mortalidad, doctor. El desenlace fue ahí como más o menos. Entonces yo se la respondo con otra pregunta. ¿Y será que usted, si disminuye hospitalizaciones, controla la hipertensión, disminuye los péptidos, su paciente está menos gordito, su paciente ya no está hipertenso, disminuye el riesgo de fibrilación auricular, ¿será que no se va a morir menos? Es ahí donde de pronto la medicina de imprecisión en los estudios a veces, ¿sí? Pero realmente es un estudio positivo y nos ayuda mucho, ¿sí? Entonces, esto se los conté ya, disminución por todos los componentes de muerte cardiovascular como objetivo secundario. El principal efecto, que es lo que más nos gusta a nosotros, que no se hospitalice un paciente por falla cardíaca, porque cada vez que un paciente se hospitaliza se muere más, ¿sí? Y algo que les encanta a los nefrólogos, disminución de la falla renal. Si usted tiene un paciente que se hospitaliza menos, no se le daña el riñón y todo eso, probablemente no se le va a morir tan fácil. Y pues digamos que esto es con empaglifosina, entonces el hermano, o yo no lo llamaría hermano, el primo, dijo, yo también quiero hacer un estudio igual. Entonces yo quiero mirar si la dapaglifosina, que también ya sirve en reducida, que eso servía también en preservada. Estudio igualito, dapaglifosina versus placebo, disminución de la cantidad de eventos de hospitalización, al igual que la empaglifosina en el desenlace primario de muerte cardiovascular fue neutro. Y obviamente lo que más nos interesa, disminuye la cantidad de hospitalizaciones por falla cardíaca. Y cuando yo voy y busco la unión de los dos, pues todos los metaanálisis de ILST2 en falla cardíaca preservada son buenos. Disminuyen la muerte cardiovascular, disminuyen por segundas causas, disminuyen hospitalizaciones, disminuyen la cantidad de hipertensión y los resultados son buenos. Eso hace que a hoy, pues la falla cardíaca no la mire como la veía hace unos años, solo diurético, ¿no? Hoy yo ya sé que contamos con moléculas, una familia de medicamentos que disminuyen esa posibilidad de que su paciente con falla cardíaca se le empeore, y es por eso que probablemente el rey de la corona en el manejo de insuficiencia cardíaca preservada sean los ILST2. Al punto que en la actualización de la guía de falla cardíaca del 2022, todos sus pacientes que tengan con diagnóstico confirmado de insuficiencia cardíaca preservada, traducción mayor de 50, es una indicación 1A tener un ILST2 en el tratamiento. Cuando a mí me enseñaron epidemiología me dijeron que 1A era obligatorio, que si no tenía yo eso, más bien estaba haciendo mala medicina. Entonces es probable que ustedes busquen el diagnóstico para que le puedan ofrecer a su paciente algo que ha mostrado beneficios. Y a mí me gusta leerme los subgrupos de los estudios. Entonces, cuando yo iba y buscaba y mirábamos y nos rasgábamos las vestiduras, pero ¿por qué no sirvieron los otros? ¿Por qué no los puedo poner? ¿Qué es lo que está pasando? Miren que hay unos pacientes, medicina de precisión, doctores, que les pueden ayudar otras cositas. Cuando uno va y busca los subgrupos de los otros medicamentos, tanto en el Paraglide, que acuérdense que era para agudizaciones de falla cardíaca con sacubitril valsartán, el Paragon en esos pacientes con FEBI preservada. Los que tenían más de 60 de FEBI no les sirvió y por eso de pronto el estudio concluyó que no era muy bueno. Pero en los pacientes que tenían entre 50 y 60, las mujeres por ahí entre 55 y 57 de FEBI, sí disminuían hospitalizaciones, sí se morían más. Entonces un mensaje, si usted tiene un paciente, mujer, con menos de 60 de FEBI, con disnea, elevación de péptidos, escalas que le dicen a usted que tiene fracción de eyección preservada, no es tan descabellado que usted le ponga, aparte del ST2, el entresto. ¿Sí? Individualice. Obvio, no es una recomendación 1A, las guías lo apoyan como una recomendación 2B todavía y pues está en plan de otros estudios adicionales que si ustedes me lo preguntan, es probable que no los hagan tan grandes. Y la espironolactona. Entonces, doctor, que el TopCap no sirvió. Mi respuesta es sí, usted tiene toda la razón, doctor. Pero de pronto, si yo voy y miro algunos pacientes que tienen fracciones de eyección entre 50 y 60, de pronto pacientes un poquito mayores, podría servir. Y sobre todo en algo que se quejan estos pacientes, congestión. Es por eso que a hoy las guías dicen, DL1 y LST2, mire si se beneficia de alguno de los otros, no le dé beta bloqueadores porque los beta bloqueadores en esta condición sí nos sirven y trate todas las comorbilidades posibles. Trate la apnea del sueño, trate la fibrilación auricular. Obvio, si usted tiene que dar beta bloqueador para la fibrilación, pues es otra cosa, pero usted no se lo está dando para fracción de eyección preservada. Mire si su paciente es coronario, si su paciente es diabético, llévelo a metas de la diabetes. Si su paciente tiene enfermedad renal crónica, disminuya la progresión de enfermedad renal crónica. Y eso. Una de las personas que más sabe de falla cardíaca preservada, no pasó. Me la pasa ahí, qué pena, porque no. Listo. La doctora Lam, que es una de las investigadoras principales de los estudios de preservada, hace una editorial hace unos 2 o 3 meses, unos 6 meses más, o empezando el año, realmente publican este metaanálisis, esta editorial, y ella propone este tratamiento o esta escala que a mí me gusta muchísimo y es la que trato de aplicar en mi vida diaria. Si yo tengo un paciente que ya le confirmé el diagnóstico de falla cardíaca, está congestivo, ya la doctora en la Cleveland Clinic nos enseñó que los diuréticos y estos nos pueden ayudar, pues descongestiónelo. Si su paciente tiene más de 50% de FEBI, excluya todas las causas adicionales que tiene. ¿Será que tiene anemia? ¿Será que tiene apnea? Comorbilidades. Si usted confirma todo eso, ponga a hacer ejercicio a todos sus pacientes, a todos DELES y LST2, y de pronto aquellos pacientes en los que sean fracciones de eyección entre 50 y 60, mujeres, las características del Paragon, DELES el ARNI. Y si también cumples criterios para del TopCap, pues désela también, porque es que eso le va a poder ayudar a que su paciente vaya mejor, ¿sí? Y mire si realmente necesita algo adicional de diuréticos si está congestivo. Y trate todas las comorbilidades probables. Mensajes para que se lleven hoy a su práctica diaria. El 50% de los pacientes con falla cardíaca preservada tienen falla cardíaca con FEBI mayor del 50%. El diagnóstico de la falla cardíaca preservada es el diagnóstico diferencial de la disnea aplicando las escalas que hablamos del H2P. Los ILST2 a hoy son la terapia 1A de recomendación en tratamiento de pacientes con falla cardíaca preservada. Y no se olvide que la falla cardíaca preservada no es una enfermedad del corazón, es una enfermedad multisistémica donde usted debe actuar en todos los campos. De nuevo, gracias por la invitación y espero haberles enseñado alguito de lo que me gusta hacer todos los días. Muchas gracias, doctores.
Agradecemos al doctor Eric por su maravillosa charla. Abrimos un espacio de preguntas en este momento para el auditorio.
Si no hay preguntas, yo las hago. ¿Cuántos de ustedes aplican la escala del H2P? Juan Diego es pilísimo y sé que sí lo hace, ¿sí? Es muy fácil, hagan la escala. ¿Cuántos de ustedes le dicen a un paciente que haga ejercicio? La doctora Sonia, la he visto cuando pasa ronda y le dice, señora, haga ejercicio, ¿sí? Hay un estudio súper bonito y no sé si venga el caso. Hay muchos pacientes con diagnóstico de falla cardíaca preservada que los sometieron a un programa de rehabilitación cardíaca, 36 sesiones. Les hacían ecocardiograma y les hacían una prueba de esfuerzo cardiopulmonar antes de empezar la terapia. Y la terapia, digo yo, todo, sí, o sea, las comorbilidades. Y a las 36 sesiones, eso más o menos eran entre 3 a 4 meses, les volvían a hacer una prueba cardiopulmonar. Y en la prueba cardiopulmonar mejoraban volumen latido, mejoraban capacidad de hacer ejercicio, mejoraban el VO2 y si le hacían otras cosas, caminata de 6 minutos, caminaban más, disminuía la cantidad de beta bloqueadores que de pronto un paciente necesitaba, ¿sí? Entonces probablemente el ejercicio sea, para mí hoy, me puedo equivocar, podría ser el quinto fantástico en el tratamiento de la falla cardíaca. Bueno, ¿una pregunta adicional? Muchas gracias, doctores.
Muchas gracias, doctor Eric. Damos paso a la charla Neumonía adquirida en la comunidad para el hospitalista a cargo del doctor Jeffrey Garland. El doctor Garland es médico egresado de Mount Sinai en 1987, realizó sus estudios de medicina interna en el University of Pittsburgh Medical Center, donde también obtuvo su fellow como intensivista en neumólogo en 1994. El doctor Garland es reconocido en el Departamento de Medicina Hospitalaria del Mayo Clinic de Jacksonville por su pasión por la enseñanza y su vasta experiencia en el manejo de pacientes complejos. Welcome, Dr. Garland. Feel free to start your conference, please.
Okay, gracias. Do you all hear me?
Yes.
Good, thank you. All right. So I'm going to talk about the most recent guidelines related to community-acquired pneumonia. These hadn't changed in a good number of years since 2007 and recently have. And the way they do it is by giving sort of question and answer. So I'm going to do it the same exact way. When I put up this lecture together, I learned a lot, so I'm hoping you will as well. So I have no disclosures. So what I'm going to do is give you several questions. This is not audience response, but just think for yourself what you would think the answer is. We're going to get back to all these over time. So patients with community-acquired pneumonia requiring inpatient admission should have the following tests routinely performed. So sputum culture, blood cultures, urine for Legionella and pneumococcus, all the above or none of the above. So I'll give you a minute to just think about what you think your answer is for this, and like I said, we'll come back to it. Second question, which of the following statements is true? Minimum duration of antibiotic treatment of CAP is 5 days. Patients suspected of having aspiration pneumonia should have anaerobic coverage in their antibiotics. Follow-up chest x-rays should routinely be done in patients after they have pneumonia. In the setting of a negative urinary Legionella or negative urinary pneumococcus, Legionella treatment and pneumococcal treatment can safely be withheld. In the setting of a very low procalcitonin level, less than 0.01, likelihood of CAP is so likely by virus that antibiotics can be withheld. So there could be one or more than one of these that are true answers. And if you could just think about it for yourself, how you would answer this question. Okay, the third question. Which of the following is true? Again, it could be a combination of different things. Amoxicillin can be used alone to treat some patients with community-acquired pneumonia. Tamiflu should only be given to patients admitted to the hospital for CAP who have symptoms of 3 days or less. For patients with known pneumococcal pneumonia, the combination of Rocephin and Levaquin should be used instead of Rocephin and Zithromax because of the high level of resistance for Zithromax, which is over 25% in most of the world. Or all these could be true, or none of these could be true. And again, I'll let you think about these for a minute. All right. So the first question one of the first questions we're going to talk about is, should sputum gram staining culture be obtained? So typically we obtain them on everybody, but is that actually the right thing to do? Is the evidence-based medicine simplify that? In the outpatient setting, those aren't always checked. But in inpatients, we pretty much use them on every patient. But is that correct? The truth of the matter is, it's the sicker patients, or those predicted to be sick, that actually benefit from checking a gram stain and culture on sputum. So those who have severe community-acquired pneumonia, those who qualify for needing MRSA or Pseudomonas coverage, and I'm going to go over that, those previously infected MRSA or Pseudomonas, and those at high risk because they've got recent antibiotics within the last 3 months. The recommendation, and this is from the American Thoracic Society and Infectious Disease Society of America, is actually only to do gram staining cultures on the patients in this group. So these are old criteria, but the ATS-IDSA has not changed them since 2007. And this is trying to define who has severe community-acquired pneumonia or not. On the right side is the major criteria. We need just one of those, which is obvious to everybody. Septic shock requiring vasopressor support, or respiratory failure requiring mechanical ventilation. If it's pneumonia doing that, obviously it's severe pneumonia. But they also say you could have 3 of the minor criteria, which is high respiratory rate, a low PaO2 to FiO2, so that's PaO2, if you're looking at a blood gas, you're looking at the PaO2 in the blood gas and the FiO2 given as a fraction. So for example, if the PaO2 was 80 and the FiO2 was 80%, which is 0.8, it would be 80 divided by 0.8, which is 100, which is very severe. And in fact, that's how we define ARDS, or at least it has been defined. Less than 300 is mild ARDS, less than 200 moderate, less than 100 severe. And that's all using the PF ratio. Multilobar, uremia, low white count is actually a bigger concern for severe pneumonia than high white count. Significant thrombocytopenia, again, low temperature, worse than high temperature, and of course, hypotension, not requiring vasopressors, but requiring fluid resuscitation. So this is how they define severe community-acquired pneumonia. This is important because we're going to use this definition later on. So we talked about risk factors, and ultimately, of the bacteria that are out there, the 2 that we focus on the most, in part because it changes our treatment options, are going to be Pseudomonas and MRSA. And so these are the risk factors for Pseudomonas. So recent antibiotic use, recent hospitalization, obviously immunocompromised, chronic pulmonary disease like COPD or pulmonary fibrosis, aspiration event, and then a lot of other medical comorbidities. So basically sick patients, recent antibiotics, recent hospitalization, immunocompromised, those are the ones we're looking at. Risk factor for MRSA are a little bit different. So the recent antibiotics within 3 months is still there. MRSA, risk for having colonizations, end-stage renal disease, IV drug abuse, homosexual men, prisoners, all have this increased risk. Necrotizing or cavitary pneumonia. So Staph aureus is one of the most severe forms of pneumonia. It's a lobar pneumonia, and it often eats away at the lungs and causes necrosis, and you get necrotizing or even cavities. So initially it's necrosis, which is like liquefaction, and then eventually you can actually even get tissue that's destroyed and left with air. So it's a cavitary lesion. So when you see those type of things, Staph aureus, which is meth-resistant Staph aureus or meth-sensitive Staph aureus, are at risk for this. And interestingly enough, we always talk about MRSA. MSSA, methicillin-sensitive Staph aureus, is actually just as dangerous as MRSA. The difference is there's a lot more antibiotics that cover MSSA. Obviously, empyema, and then patients who are extremely ill, sepsis, shock, ventilator, and so forth. So the second question we came up with, again, should blood cultures be done? Well, the first one is probably pretty obvious. We don't do blood cultures on outpatients. But again, should we do them on inpatients? And, I think most of us actually do. We generally do. The answer is, though, is that, again, there's no data that they're going to change overall prognosis, treatment, modalities, and so forth by doing blood cultures unless these are the very sickest patients or at risk or previous history of MRSA or Pseudomonas or recent antibiotics. So again, they are not recommended for all patients. So as I went through these guidelines, I learned a lot, and hopefully you're all learning a lot as well. So how about the Legionella pneumococcal urinary antigens, only recommended again for severe CAP? And for Legionella sputum culture, one thing I'll also mention is that these are good for ruling out pneumococcal and Legionella pneumonia, but not for ruling in. So negative predictive value is over 90 to 95%, but positive predictive value is only about 70%. So a lot of false doubts. They only help, if you do them, they only help to rule out, not rule in. And again, we order them probably in just about everybody, but we're not right. They really should be on severe CAP. So should respiratory samples be tested in patients, should be tested for flu? What they recommend is doing it during flu season. That's pretty straightforward. Consider it in non-flu season, particularly in your sicker patients. What's interesting is flu increases the risk of gram-positive organisms. So strep pneumococcus, MSSA, MRSA, and so forth are increased risk related to flu. Next question. Should procalcitonin be used in addition to clinical judgment to determine what patients are treated with antibiotics? And what they basically said is do not use procalcitonin to make a decision if we should treat or not treat. They're really used and they've been studied for de-escalation of antibiotics, not for a decision of whether to treat or not. So they say when CAP is suspected clinically and radiographically, you treat. Even if procalcitonin level is low, you would still treat, and vice versa. As well, they make a comment to not use the Procal to differentiate between pneumonia and bronchitis or pneumonia and a URI. Now, a little bit confusing is they say that while they're not differentiating based on this, they do go ahead and say that the higher levels are more likely bacterial and lower levels more likely viral. They just don't think that you should determine if you're going to treat or not based upon that information. I'm going to leave this for now. It's a reference for you to look at if you're interested. Next thing, should a clinical prediction rule be used in addition to clinical judgment to determine if a patient needs to be treated as an outpatient or inpatient? So you're making an admission decision. Patients in the emergency department or in your office, you want to know, can I give outpatient treatment or inpatient treatment? And in fact, using a clinical prediction rule does actually increase the ability of making an accurate decision. And the two that they look at are the pneumonia severity index and the CURB 65. Just a couple more of these. Should a clinical prediction rule be used in addition to clinical judgment to determine if a patient should be treated on the general medical ward versus higher level? So first we were looking at should they come in the hospital or not. Now we're saying general medical ward versus a higher level, meaning ICU step down telemetry. Well, obviously, if a patient needs vasopressors or mechanical ventilation, they go to the ICU. If not, what they put together is the minus severity index. So if there's 3 of those or not, and they also use, again, the pneumonia severity score and the CURB 65. So what I want to break to here is to give you the quick upfront summary of recommendations that they're going to give for the treatment of community-acquired pneumonia in different settings. And the reason I'm doing this here is we're going to go into a lot more detail after these 2 slides, but I think it can get confusing. And so I sort of did kind of the down and dirty here. These are the basics. There's a lot more options. I think these are, if you remember this, then you're actually going to be in good shape. So in general, if you have no comorbidities, this answers one of the questions. Amoxicillin can be used for outpatient treatment in patients who are otherwise young and healthy. If not, augmentin, which is amoxicillin clavulanate, plus Zithromax. For inpatient, here's something interesting. So a lot of people, when we admit people with non-severe or severe CAP, if there's no risk factors for MRSA or Pseudomonas, they can just get Rocephin and Zithromax, even for severe CAP. So just because they're severe doesn't mean they need to get covered for MRSA or Pseudomonas unless they have risk factors for those things. Now, inpatient, if they've gotten IV antibiotics in the last 3 months, or risk for MRSA, then we're going to treat, and it's based upon the severity. So if they're non-severe or severe, right? So patients got an IV antibiotics in the last 3 months, has risk factors for MRSA, we discussed those. We're using Rocephin and Zithromax. We do a nasal MRSA culture, and we add Vanco if the MRSA culture is positive. On the other hand, they're telling us if pneumonia is severe, start the Vanco up front and use the nasal MRSA to de-escalate. All right. Last slide. So in patients with non-severe history of IV antibiotics in the last 3 months and risk factors for Pseudomonas, again, the same kind of thing, Rocephin and Zithromax, and then you culture, and if positive you had treatment, if they're severe, you can do treatment up front. Let me now skip to some of the more detailed. So we've, again, talked about most of this. What you see in dark are the areas that I used in my sort of summary slides, but there are other options. So we talked about patients in the outpatient setting, community-acquired pneumonia. If they're healthy with no other comorbidities, no risk factors of MRSA or Pseudomonas, they can get amoxicillin. I didn't mention doxycycline because, again, I was trying to give you the real basics. But if a patient has a significant penicillin allergy, doxycycline can be used. It doesn't have nearly as much data for efficacy, but it can be used. If a patient has comorbidities, and these are the ones they list, right? So just think about a chronic organ disease, diabetes, alcohol, malignancy, or asplenia, then you shift here to most commonly augmentin plus macrolide, but you could also choose cefpodaxine or cefuroxime, second generation cephalosporins plus a macrolide. And the third option is a fluoroquinolone with activity against pneumococcus, which the ones we have available, basically levofloxacin and moxifloxacin. They actually can be used alone, but that's considered a second line. All right. So let's talk a little bit now about how we're going to treat these different organisms. We worry again about MRSA and Pseudomonas. MRSA, as you all know, vancomycin is typically the first drug of choice. If it cannot be used for some reason, linezolid is typically used. Keep in mind that daptomycin, which is a great drug for MRSA, everywhere except the lungs. It gets broken down by surfactant, and so actually is not effective. So do not use daptomycin for MRSA pneumonia. Vancomycin actually does not get great tissue penetration, and which linezolid does, but despite that, in head-to-head studies, they've both been shown ultimately equally efficacious. And so typically, vancomycin is used for MRSA. Now, what options do we have for Pseudomonas? Well, the two most common we're going to use are high-dose Zosyn, so pip tazobactam, 4.5 Q6, or cefepime, 2 grams Q8. There's a few other options. Cefepime is a 4th-generation cephalosporin. Ceftazidime is a 3rd-generation that actually works. We have the monobactam as Trianam. We have the carbapenems and meropenem and imipenem. And the one I didn't put here actually is aminoglycosides, such as gentamicin and tobramycin, and they're generally not used, almost never used. So we spoke about this before. These are patients, again, who have non-severe CAP and no risk factors. These are the patients you admit all the time, which we're, as hospitalists, these are the ones we're usually admitting. And typically it's ceftriaxone and a macrolide, which is usually Zithromax. And I told you we have other options. So Unison, which is amsulbactam, cephalotaxine, ceftaroline are all options as well. But again, the most commonly used is going to be ceftriaxone. In non-severe, a second line is the monotherapy with levofloxacin or moxifloxacin, and that's in non-severe. Now, in severe, patient with severe CAP without risk factors, again, we talked about ceftriaxone or a few other options, and then a macrolide or a fluoroquinolone. But the option of fluoroquinolone alone, which we had for non-severe, is no longer recommended. And the reason we have options here is we're basically covering, as you know, these drugs are covering for typical organisms, our lobar pneumonias, such as pneumococcus, Haemophilus influenza, Moraxella, and so forth. These guys, macrolides and fluoroquinolones, are the ones that have activities against the atypical organisms, meaning Legionella, Mycoplasma, and so forth. All right, antibiotics in patients who have either one, severe or non-severe, they've had MRSA before. If they've had MRSA before, you're treating MRSA. So we talk about antibiotics within 3 months. If they've had previous MRSA, that's high risk. Colonization is the other high risk. Antibiotics within 3 months is less of a risk. Again, we're using our typical ceftriaxone and a macrolide. We then add MRSA treatment, and we get nasal cultures to see if we can de-escalate or confirm the need for continued treatment. So we're treating with nasal cultures to help. How about in patients with non-severe CAP with IV antibiotics in the past 3 months and risk factors for MRSA? What I was trying to show you here is, as opposed to known colonization or known previous MRSA, antibiotics in the last 3 months does increase our risk for MRSA, but not to the same degree. So again, ceftriaxone and macrolide, and then it says obtain cultures, but only give MRSA treatment if the cultures are positive. How about severe CAP? Same thing. And again, what we're doing here is we're adding MRSA coverage automatically and then drawing back if the nasal cultures come back negative. So looking at degree of severity, if they're very sick, we're starting off with MRSA coverage no matter what the initial nasal shows. We're going to wait for the nasal PCR before we're going to stop MRSA coverage. Non-severe CAP or severe CAP with respiratory isolation of Pseudomonas, and then again, the same drugs we talked about, usually Zosyn or cefepime plus a macrolide. What's important here is you want to try to pick a drug that has not been used in the last 3 months. So if patients receive Zosyn in the last 3 months, we generally should go over to cefepime and vice versa. When I get a patient who's been in an outside hospital and I can't find out what they've gotten, I'm not sure how it is, we're in Colombia, but by us, Zosyn is the drug that's most commonly used by far. So I'll actually empirically use cefepime in that setting. But again, we're typically using here is an anti-pseudomonal agent plus something for atypicals. How about non-severe hospitalization antibiotics in the last 3 months and risk factor Pseudomonas? Again, these are non-severe, so we're holding pending cultures, whereas in patients with severe, we're going to treat pending cultures. And then patients with hospital-acquired pneumonia and ventilator-associated pneumonia, in general, should get treated for MRSA and Pseudomonas because there's a good deal of MRSA and Pseudomonas running around in the hospital. This is the summary I gave you all before. I'm just going to go through it now to the next slides. All right. So this is something I think is important and interesting. So basically the question is, should inpatients thought to have an aspiration pneumonia get anaerobic coverage? In the past, we generally did it. Why is that? Because mouth flora are typically strep species and anaerobe species. And so we typically recommended to treat for them. It is clearly not recommended to treat for them now. So for example, a patient came in, outpatient, non-severe, no MRSA, no Pseudomonas risk, who have a aspiration pneumonia or pneumonia you think is due to aspiration. You would use ceftriaxone and zithromax or one of the other options we gave. You would not have to do anaerobic coverage. Now there's two exceptions to this. And the exceptions are going to be patients who have either an empyema or a lung abscess. And the reason is they have very, very high burden of anaerobic organisms. So high that the organisms can become systemically important. And so patients, again, with empyema, pleural fluid infection, pleural fluid that's infected and becomes basically organized and full of bacteria and pus, versus lung abscess, those are the two that you're going to treat up front. There's one other group that's not discussed here that I always at least think about, and that's a post-obstructive pneumonia with malignancy, where we typically get a ball valve effect, where secretions can go into the distal lung but not get out. I always think about it in these patients, but there is no good evidence-based data for that, and certainly not for anything else. Should patients be treated with corticosteroids? And they're saying severe CAP, basically with septic shock, that's refractory to treatment requiring vasopressor support. And the dose is typically 50 milligrams every 6 hours. We know about side effects related to this, including possible infections. And influenza infection mortality may be increased with use of steroids. So if a patient has influenza and actually aspergillus, those are two organisms that giving steroids can actually make things worse. Just keep those in mind. And there's a couple studies I put here about hydrocortisone in severe sepsis that are more or less what I told you before. There's an interesting study that came out recently with low-dose salumedrol continuous drip. There may be an advantage to that. Now, we talked about this, so should patients with CAP who test positive be treated for antiviral therapy with influenza treatment? And the answer is yes. And even though Tamiflu is more effective in the first 48 to 72 hours, the recommendation is any patient admitted to the hospital with positive flu should get treated with Tamiflu. All right, how about outpatients and inpatients who are improving? What is the appropriate duration of therapy? This has shrunk down dramatically since I started practicing, which was a long time ago. We were giving typically 10 to 14 days, more like 14. Then it became 10, then 7. And now what it's showing for most organisms causing community-acquired pneumonia in patients who are improving and responding well to the antibiotics, a 5-day course should likely be acceptable. A couple of exceptions are the MRSA and Pseudomonas. They spread out a little bit to 7 days. And even bigger infections are ones who have pneumonia, but also deep-seated infections in addition. So they've seated their heart valves or their brain and so forth. And the studies have shown, I told you the use of procalcitonin is actually de-escalate. And several studies have shown that this procalcitonin level can be useful to help patients have a shorter course of antibiotics. Should x-rays be obtained? They're not recommended. And again, when I was in training, we all said we got to get an x-ray a week or two later, make sure pneumonia is getting better. Patients clinically improved, with no other complications that you're expecting, you can stop right there. And I think I'll stop here for questions or comments.
Thank you, Dr. Garland. There are no questions in the hall right now.
Okay, we'll see you all tomorrow morning.
No. See you tomorrow, Dr.
Okay.
Garland.
See you tomorrow. Thank you. Gracias.
Bueno, muchas gracias a todos por la asistencia y la persistencia en este día. Los esperamos mañana a partir de las 8 de la mañana. Muchas gracias.
Corte.